On the 5th of September 2022, a 36-week pregnant woman in Jalilum village, Ribhoi district, had to be carried to the nearest health institution on a makeshift bamboo stretcher. Community members carried the woman for 5 kilometers to reach Patarkhma CHC. Fortunately, she delivered a healthy baby girl. Such incidents are not uncommon in rural areas of the state where some women still opt for home birth instead of institutional delivery, and many times complications arise. Although the state's maternal mortality rate and infant mortality rate are on the decline, as informed by Chief Minister Conrad Sangma on the floor of the House during the autumn session, it is still a cause of concern for the state.
After a lot of work that has been done by the departments, today the infant mortality rate from 34, it has come down today to 29, and we are almost at the national average because of the efforts that are being made by the department now. A lot of hard work is going into this, and this has been in fact the basis of a large number of other programs that have happened, including the self-help group movement, which I was talking about yesterday, started with our concern about maternal mortality rate. So I can assure the honorable member and all the other members that the maternal mortality rate number is one of the key bases and key points around which a large number of the programs of the state government are running, and definitely we are all very concerned and we are making all-out effort to ensure that this is reduced. As I said, sir, even in the month from January to May 2022, we saw a 40% reduction in the maternal mortality rate.
In order to tackle such issues, the state government had come up with the Chief Minister's Safe Motherhood Scheme. Through the scheme, the government is setting up transit homes and healthcare centers for high-risk mothers, arranging transport for pick-up and drop, encouraging family members to accompany the mother, and more. Principal Secretary Health and Family Welfare, Sampat Kumar, informed Assembly Channel that following the incident at Jalilum village, an inspection was conducted to understand challenges faced by pregnant women in remote areas. He also spoke on the interventions undertaken to improve the overall healthcare system in the state and increasing institutional delivery. Take a look.
The idea is that it's monsoons and the road condition, like we also couldn't go. We had to stop and then we had to walk for a kilometer trekking, and then we went to the place. So the idea behind our visit was essentially to see like how in the remote areas, what are the challenges, how actually those challenges can be reduced, especially in terms of providing better maternal care. You are aware the government has brought out a new program. It's called Chief Minister's Safe Motherhood Scheme. So through that, the idea is that like how actually we can bring such patients who are living in the remote places, hard to reach areas, well before their expected date of delivery. So that what happens is that when the situation arises, especially when the labor pain, when the woman, the pregnant woman starts experiencing labor pain, she should be able to go to the nearest facility as early as possible, at least in 30 minutes to 1 hour period. You should be able to reach the nearest community health center or the primary health center. So we have a large number of hard to reach areas are there, especially when we analyze this entire maternal health and where actually the problems are there. It's mostly the hard to reach areas. So we went there to really understand how, so to educate the people also about this particular program. And what the incident that you are narrating is essentially it's a positive initiative. The reason is that before this incident, there was one maternal death in that particular village. It's called, Jalilum village. So we went there to have this maternal death review. In fact, I went along with my colleague, Secretary Health, and also the Deputy Commissioner, and also the Director Health Services. So we all went there to really understand why it is happening, why the maternal death occurred. In fact, it's again a case of serious, I would say refusal. The pregnant mother was told to go to the health center, but she refused to go, though she was a high risk patient. Because why she was high risk patient? Because it is a fifth gravida for her, and she's a high risk patient, and she has been told to to go, but like she couldn't go. The reason is that there is a lot of effort is required to bring awareness among the people, especially living in the remote areas, about the importance of the maternal health, because they have, over a period of time, in fact already she has many births happened at home, and she feels that that can be managed at home. So it's an effort to increase that awareness, and also to bring a lot of coordination, because when the mother is refusing, then we need to really bring a lot of community support. So we also have discussed with the headmen. So they all tried. In fact, they brought some traditional birth attendant or untrained dai from Patarkama. They spent money in bringing untrained dai, but they couldn't actually inform the health center. So there is so much so that we need to build that. So when this incident happened, after this incident, the next incidents what you mentioned has happened, where pregnant mother was brought in, because they understood the importance of taking them to the hospital. So the ambulance went till the point where actually ambulance could go, and then the entire village community supported the pregnant mother, and she survived. And otherwise it would have been a very complicated case. And we met the mother and child also in that village. They were quite healthy and happy.
The state is reeling with high mortality, maternal mortality rate. So there are so many programs, yet people refuse to
but my point is that it takes a little time. Now there is a significant improvement. I'll give an example of a district, West Khasi Hills district. So the same West Khasi Hills, all these places, in fact interior places, there's a lot of refusal. But now we could see a significant improvement. We used to have, our institution delivery used to be less than 50%. Now it's about 65%. So it's still, it's a significant improvement in terms of the uptake. So it takes some time. That's what now our focus is, concentrating on those remotest parts, and see that how that can be provided. That's why we went to Tamil Nadu also. And Tamil Nadu government was very kind enough. They have agreed to train our in-service doctors. So that what happens, like suppose Patarkama is there. Patarkama is the remotest place, you are aware. Patarkama to travel, from Patarkama to Nangpo, it takes about 2 hours. So what Patarkama is a community health center that requires to be upgraded into a referral unit, first referral unit, where even actually if there is a case of a surgery required to be done to remove the baby, like a cesarean or anything that has to be done. So we are going to have that capacity. So we are going to send the doctors from all these remote CHCs and PSCs for this training, where actually they would be trained to manage the lot of this obstetric care. Otherwise, obstetric care is generally provided by a gynecologist. We don't have specialists. In fact, we have even we have advertised so many times, we don't have many specialists in the state. So that's why we brought one program called Adarsh program, where actually we are training our in-service doctors for a 2-year diploma course. So that that program is starting from this year. So every year about 22 doctors are going to be trained under that Adarsh program in the current capacity, because they are going to be trained within the state. Besides that, we are also going for a 6 months program, which is actually we call it like CMOC and EMOC, basically emergency obstetric care, and also the anesthesia, LSAS. For example, we have one LSAS doctor trained, 6 months trained doctor, and one gynecologist in Sora. They are doing wonders because they are trained. they're able to take care of entire lot of confidence of the people. People go immediately to the CHC. Sora is one of the best run community health center. So that way we are trying to get that kind of a facility in every CHC. We have about 30 CHCs. Sora is exceptional because they have this trained doctors are there. So we are actually now, because even to train these doctors, you need a medical colleges or and hospitals to be trained. So Nigrim is giving some help, but that's not sufficient because we require a large number of doctors to be trained. That's why we went to the government of Tamil Nadu, because it's one of the I think it's the only state perhaps in the country where a large number of people go to the public health systems, not the private health systems. So it's a public health systems are very well run, so we can also learn a lot from them, and also they are going to provide training. So our idea is that we need to train about 120 doctors in the next 2 years to make sure that about this 30 peripheral like Patarkama kind of community health centers would be made as a first referral units, so that the care can be provided. So this is one part. This is supply side, where how actually we are providing the services to the people. But the other is that, like what you just asked me, how actually people can be educated to take those services. That's where the process is happening. So one of the things what we are doing is that this entire the field visits we made every Wednesday. We are making these field visits to some of these places, interior places where there is already some problems are there. So as a team we are going, not like health department, social welfare, community and rural development department, that is especially the self-help group program called MSRLS and NRLM programs. And we are taking this entire, as a team we are going and understanding the problems. Basically through SHGs we are trying to educate people, because women self-help groups have come up in every village. And we also have brought this village health councils. They also had to come up. So far we have got about 1400 villages only. The village health councils have come up. Now every village the village health councils are being formed as an elected body involving the traditional headmen. So what you saw in Patarkama, it was again because of that headman involvement. So we are seeing that community leadership in these issues. So they're taking up as a very important issue. So we are using this distributed leadership model for healthcare.
Yes. Many we saw in the floor of the house also that many legislators raised the issue of infrastructure, the requirement of infrastructure especially in the border areas. So what do you have to say about it?
It is that's what it's being provided. That's what I said. The facilities, in fact. I'll give an example of Jengjal is one place in Garo Hills where we have come up with a sub-divisional hospital with CMC doctors, and today actually that's catering to a lot of people. So basically the idea is that one is infrastructure and there is human resources. So both are important. And the third one, most important thing, is that how actually we are working with a mission approach. How actually proactively we are reaching out. So that's what we have seen today. We are also focusing a lot on that, and we have seen that every especially the doctors and healthcare workers, social welfare officials, and rural development officials, everyone coming together and seeing that this is something that we all have to address. There is a strong sense of purpose. So building that strong collective sense of purpose is also important. That also we are working on that, because that only will sustain. So as I said, in West Khasi Hills, every year from we used to get about 12 to 11 deaths between January to May. This year from 12 it has reduced to 2. So it's a collective effort. If you work together, definitely. That's where we also have this weekly review meetings. Besides the weekly field visits, we also have the weekly review meetings with the districts. Today we had that meeting. We actually analyzed, we understood. We also learn. Suppose if a maternal death occurs, we also understand why it has happened, how actually it would have been prevented. So that like next time, the way in that village, the first one incident happened, next step was entire village actually responded in a way to save that mother. Today the mother and child were so happy. So it's a participatory model, development model where, community also has to, everyone has to come together and work. It's a health is something that requires that kind of a participation.
Many doctors are, we're getting reports that many doctors are leaving Negrims, and that it causes huge chaos.
Yeah, I think, but we have a very competent director is there. I think he's looking after that particular issue, how to handle it. I'm sure. See, one is that there is a dearth of specialists. This is the truth. When we went to Tamil Nadu asking for whether they can send some specialists for some time till we get our own specialist, they said it's a very difficult thing. They can train our doctors, but sending their doctors here for some time. So there is a serious dearth of specialists all over the country, not only here. So that we have to take that. But one good thing about Negrims is that they have a good, it's a national institute, and recently they have also actually taken a decision to make it as a national institute of importance, or some, there is some equivalent to kind of a aims, some decision is going to be taken, or some discussion is happening on those lines. So I'm sure those problems will be resolved.